Good morning, everybody, to the people on Zoom. I'm Carolina Reduzzi, the director of the liquid biopsy platform that, together with the hematology oncology division, have organized this series on liquid biopsies. And today is the second seminar, and the topic will be the liquid biopsy technologies from Menarini Silicon Biosystems. And here to talk about it, we have Kuhr, which is the Vice President of Medical Affairs North America for Menarini Silicon Biosystems. Okay.
All right, thank you, Carolina. First, I'd like to thank you for the invitation to join the Liquid Biopsy series. As Carolina said, my name is Frank Kuhr. I'm Vice President of Medical Affairs at Menarini Silicon Biosystems. So it's my pleasure to be joining you today to talk about our assays and the clinical utility associated with circulating tumor cells, also called cell search, and our cell-free DNA RNA assay called Menarini search. And I'll be speaking today about their applications in cell and tumors. To start out, I want to give you a brief introduction to Menarini Silicon Biosystems, which is a small diagnostic subsidiary of the Menarini Group. The Menarini Group is a large privately held biopharmaceutical company based out of Florence, Italy. Been in business for over 135 years, and we operate in over 140 different countries, employing about 17,000 people. And the Menarini Group also owns Stemline Therapeutics, which is based out of New York City as well. And they are the manufacturers of elacestrant, the ESR1 mutated targeting therapy in metastatic breast cancer. And Menarini Silicon Biosystems is the manufacturer of cell search, like I said, which is the first and only FDA-cleared platform to evaluate circulating tumor cells in metastatic breast, prostate, colorectal cancers. We have we offer this test through our CAP accredited lab right outside Philadelphia in Huntington Valley. So the original FDA clearance was back in 2004, like I said, in metastatic prostate, breast, and colorectal. And it wasn't until 2016 that Menarini Silicon Biosystems purchased cell search from Janssen. And at that time, the model was a decentralized testing. So we had deployed instruments all over the country, and we sold kits to different institutions. But over the course of the last couple of years, we've been transitioning from a decentralized model to a centralized model, offering all of our testing from our CLIA lab right outside Philadelphia. And in that process, during that time, we've also been expanding the applications of circulating tumor cells. So not just the FDA cleared prostate, breast, and colorectal. Now we cover many different solid tumor and liquid tumor types. And then even more recently, since we can isolate and purify these circulating tumor cells, we've been offering biomarker testing on those captured CTCs. See here, HER2 and ER for most few. And in the last couple of years, we've added to the portfolio not just analyzing circulating tumor cells, but circulating cell-free DNA and RNA. So we are the only CLIA lab that offers both CTC enumeration, CTC phenotyping, as well as cell-free DNA and RNA. As I mentioned, there's 20 years of clinical data already, hundreds of publications, and we've been involved in well over 100 clinical trials. So as we speak today, this is what our menu looks like. We, of course, have the original FDA-cleared breast, colorectal, and prostate with a host of other LDTs. So it's the same platform, but they're not FDA-cleared. More recently, we offered last year a circulating melanoma test. And we've been making a lot of progress with our CMMC assay, circulating multiple myeloma test. And this is applicable in myeloma and its precursor conditions, MDUS and smoldering. And then in addition to evaluating circulating tumor cells, we are, as I mentioned, we're now offering biomarker analysis with a strong focus on HER2, PD-L1, and ER. And we are actually, always looking to expand our biomarker detection. For example, later this year or next year, we're hoping to offer biomarker on plasma cells for BCMA, GPRC5D, and FCRH5. Okay. So for a long time, surveillance of CTCs and circulating nucleic acid have shown to be adding clinical value to the way patients are managed by offering deeper insights into their current disease status and any signs of progression, oftentimes earlier than imaging alone. And so at Menarini, we are utilizing these intact cells that are shed from the primary or metastatic lesions. We pick that up in 7.5 mL of blood. And now, as a complement to that, we are offering Menarini Search, the cell-free DNA and RNA. So together, we feel like we can offer a unique perspective on the tumor microenvironment and the genomic architecture of those tumor cells.
And do you do all three with one tube of blood, 7.5, or do you need more?
Could not have asked that question at a better time. So currently, the tests are separate. And so Cell Search is the CTC tube, which it's called Cell Save. And it's a proprietary tube that preserves cells for up to 96 hours. So, having a CLIA lab model on the East Coast, it works really well for us because we can receive samples from all over the country. And we have that 96-hour window to receive and process. And so in that time, Cell Save 2 preserves a three-dimensional architecture of the proteins that we're looking for surface cells. Currently, Menarini Search, a different tube, 10 mLs of blood. We isolate the plasma and look for circulating acids there. We hope to, in the future, combine the test into one tube, but we don't have that validated yet. So it's a great question.
Where are you in Philadelphia?
It's called Huntington Valley, so it's on the north side of Philadelphia. So the configuration of the CTC kit looks like this. We selectively target cells that have EpCAM expression, and we co-stain with cytokeratin. And this selectively looks for epithelial cells. And importantly, the EpCAM antibody is fused to a ferrofluid microparticle that allows us to magnetically isolate those cells once we bind to them, and then wash away all the cellular debris or other non-specific targets. And then importantly, we also stain for CD45 to exclude leukocytes, for example. So at the end of that, we have a highly enriched population of epithelial cells. So over the last years, there's been literally hundreds of publications characterizing the performance of the CTC assay and its prognostic value in terms of long-term outcomes, PFS and OS. And during that process, the thresholds were established of those patients who would have a more unfavorable prognosis, so in prostate and breast cancer, that's greater than 5 CT, or under 0 to 4, those patients have a more favorable prognosis. And for colorectal, it's a little bit lower. That cutoff is 3. This was the seminal paper published in 2004 by Dr. Krista Finelli from this group when he got at MD Anderson. And what he showed was that in a multi-center metastatic breast cancer setting. They evaluated about 180 patients and took a baseline reading and then one at follow-up. And they established that threshold of patients who were below 5 had superior PFS and OS, as showed here. And then those that were above 5 had a less or more inferior probability of PFS and OS. And so it was that initial baseline reading persisted through follow-up. And so both time points were significant in terms of being associated with the longer-term outcomes of PFS and OS. So this was the first paper that showed that CTCs were an independent prognostic factor, irrespective of treatment or disease subtype.
Excuse me, did this come before the prostate papers? From Shear
Yes,
and
before
Devoto?
the prostate.
Before the prostate.
Yes, that was the first one.
Yeah, so this was 2004, so quite some time. Actually, we just had that 20-year anniversary last year from that study. So fast forward 20 years, earlier this year, this paper was published that predicted global pooled analysis. So also looking at metastatic breast cancer patients, over 4,400 patients evaluated with many different randomized controlled trials. And what they showed was that what Dr. Christofinelli initially showed, that baseline and follow-up have very strong prognostic implications. So those patients that are CTC positive at baseline and follow-up have the worst prognosis. And patients then who are positive but turn negative have a better intermediate prognosis. And those that are negative, positive, negative are in the middle. And then those who are CTC negative at baseline and follow-up have the best overall survival. And so it really reaffirms that initial finding in hundreds of studies and in this pooled analysis of over 4,400 patients. So we see this carries true in the other indications. This is a study that was originally reported at ASCO in 2023 by Dr. Andrew Goldkorn at USC. They are looking at newly diagnosed prostate cancer patients, about 500 of them. And the question that they asked is, can CTCs at baseline have a prognostic significance in terms of how patients are going to do later? Because in this population, the outcomes were so variable. And what they did was they looked at patients who were receiving 2 androgen receptor blockades versus 1 androgen receptor, or Terenol, which is a CYP17 inhibitor. And what they found was that baseline, most of the patients, 2/3 of them, had 0 CTCs. And about 20% had 1 to 4, and 12% over 5. And how that correlated with outcomes is as follows. As you would expect, patients that had 0 had the best PFS and OS. 1 to 4 had an intermediate, and those greater than 5 had the worst PFS and OS. So in this analysis, you can see these represent patients across the treatment arms. So the study was actually a negative readout. Adding orterenol to androgen deprivation did not confer a benefit. But authors concluded that CTCs, just at the baseline reading, can identify patients who have a more aggressive biology, qualify for more aggressive therapy, or even be enrolled in trials.
Right.
So many people appreciate now prognostic significance of CTCs and the applications in these different solid tumors. But so naturally,
I'm sorry, I have a question for the previous one. So would you suggest, based on this data, that early on you can use this test to select the patients who would benefit from orterenol?
well,
Perhaps.
maybe not orterenol, but
Terenol's over.
Or any other type, right, of experimental treatment, AR inhibitor treatment?
So, well, this is the question, right? And this was the conundrum with SWOG 500, where the test identifies patients who are at higher risk because of the amount of CTCs that are inhibited. But just changing to a different chemotherapy in SWOG 500 did not confer a benefit. And then in this study, adding orterenol to androgen deprivation
Negative study.
didn't do anything either. So it's a matter of understanding the biology. Perhaps, by doing the complementary test of cell-free DNA and RNA, we could have a better understanding of what a better targeting strategy treat those patients who have.
The metastatic CRPC data published by Scher and Navona was way years before this. And showed that if, you know, if they went from 5 to 0, they did better.
Yeah, so actually we've,
So it's prognostic more than predictive of responding to arterial.
yeah, I mean, it's very interesting. We worked with Howard Scher,
That's what I'm saying.
and he had the notion of driving patients to CTC 0, but not everybody can get there. And so, you know, that initiative is something we were collaborating with them on to package to the FDA in their biomarker qualification program. But getting patients to 0 is not such an easy thing. So we are rethinking that strategy about maybe just having % drop in CTC value. And that was shown actually in the Crystal paper in 2004. Patients that had over 5 CTCs at baseline was about 49% of that population. And then the follow-up, only 30% at about 5, inferring that there was a therapeutic benefit. So it's just a matter of finding.
But going to your comment that you said you need to understand the biology, do you plan to incorporate transcriptomic analysis of CTCs in your lab?
So it's a great question. And we are starting out by doing biomarker detection, as I mentioned, HER2, and we're going to talk more about that in these slides. PD-L1. We also have DLL3 for small cell lung cancer. And you know, the other biomarkers relevant to plasma cell scrations like that. So, and I guess it's a good point to add, a good time to add that we are in the process of developing a panel, and we reported this in April at Myeloma Conference, where we can isolate the CTCs or plasma cells in myeloma, and then do next generation sequencing to understand their chromosomal architecture and if there's anything targetable there. So that's the next step, right? And so we want to do that with RNA. So as I was saying, so people naturally, they appreciate the prognostic significance of a test like this, but then they also ask, well, how can we act on the results of a test that you have? And Dr. Francois Bedard set out to answer that question with the STEAK trial. And STEAK stands for Strategic Therapeutic Intervention using CTCs. And what this involved was metastatic breast cancer, HR positive, HER2 negative disease. They looked at over 700 patients. And then they asked a question, can you use CTCs as an alternative to clinical assessment? And so basically in this patient cohort, they had a standard arm, which was therapy selection driven by clinical assessment. So they were high risk or low risk. Low risk received endocrine therapy, high risk received chemotherapy. And then in the experimental arm, they used CTCs drive therapy selection. Above 5 CTs, those patients received chemo, lower than 5 endocrine therapy. And so overall, there was a very strong concordance between clinical assessment and CTC assessment. But importantly, when there was discordance between the clinical score and the CTC score as shown here, clinical score in this patient population was low, but CTCs were high. And so patients on the CTC arm were escalated to chemotherapy. And as you can see, in terms of their PFS and OS, they drive the clinical benefit. Whereas the clinical assessment, those patients were endocrine therapy. So patients were safely escalated, enjoyed a clinical benefit from that based on their CTC count. So this was in 67% of the population where there was discordance between clinical assessment and CTC assessment. And that other 33% of discordance where the clinical score was high, but CTC was low, less than 5, those patients were safely de-escalated from chemotherapy to endocrine therapy. And as you can see, there was a non-inferior outcome in terms of their PFS and OS. And so this suggests that there's this predictive value of CTC just based on enumeration. So this
They did no CAT scans at all? They did?
well, no, there was a standard clinical assessment, so there were CAT scans, but
We did them.
it wasn't a standardized protocol that way. But these results were reported a few years ago at San Antonio, and it was kind of a lukewarm reception because the critics were saying, well, first-line therapy is not endocrine or chemo, CDK4/6. So this kind of approach is not very relevant anymore. But it takes time to protocol, enroll patients, treat them, and present the results. But Francois Bedard said, well, hold on a minute. It is relevant because now, CDK4/6 is first-line therapy, but some patients progress on CDK4/6 or they have to come off for other reasons. And so CTCs can be used in that context to understand their risk profile of greater than 5 or than 5 to inform on their next therapy.
So I'm wondering, I do not know if the studies are done. You see the CTC high, low, etc. You evaluate therapeutic efficacy. Do you have concomitant biopsy evaluation to see if the results are consistent between what you see in the tumor
biopsy
and the CTC? And they may not have to be. I'm just trying to understand which one is more relevant clinically.
Well, it's hard to say which one's more relevant, but it's a question that is going to be answered in the upcoming slides when we start talking about it too. So it's
Good.
fantastic.
Yeah. Okay.
Yeah. So, what about patients who are on CDK4/6 inhibitors? So that was the main critique for the SLEEP trial, and that kind of dovetails nicely into the case study, which actually looked at patients who are coming off CDK4/6, cases, palbociclib after CDK4/6 plus endocrine therapy. So these patients, there's about 220 of them coming off CDK4/6 inhibitor. The standard of care was receiving endocrine therapy, fulvestrant. And then the question that was asked, the primary objective was adding palbociclib to fulvestrant. Is there a benefit? This was also a negative readout in terms of PFS. Fulvestrant palbociclib versus fulvestrant alone was about 4.6, 4.8 months. So they were kind of right in line. And what was interesting was adding avulimab to that doublet doubled that PFS. So the authors concluded that this was a nice hypothesis generating study for further evaluation of avulimab or PD-L1 inhibition. But what we thought was really interesting is when you consider the CTC counts in this population, patients that had less than 5 and had similar progression-free survival, there's no significant difference there between the arms. But patients that had above 5, you can see that there was a benefit of adding palbociclib to fulvestrant and then palbociclib plus avulimab to fulvestrant. And this translated into a risk reduction of progression in 12 months of 57%, 74%. So again, showing that having higher CTs could be a good way to
Without measuring PD-L1 at all, in the population.
So we didn't have that assay available yet, but that is something that we do offer today. But that's a good point. And there's ctDNA in this. Did you guys?
Yeah. On the ctDNA, no, they looked at mutations.
No, it's a good question. No, to understand PD-L1 status for avulimab. So we talked a lot about CTCs and the prognostic value of enumeration. So now our expanding the portfolio to look at biomarkers on those CTCs. So I mentioned we have HER2, PD-L1, and ER, and we are in the process of developing other biomarkers on our assays. Okay. And back to your question about the tumor biopsy. There's been many studies that looked at original diagnostic biopsies that were HER2 negative. And these studies show that on average, about 15% of the time, CTCs are positive for HER2. So even though the metastatic or primary biopsy is negative for HER2, CTCs do have that expression. And emphasizing that there's some heterogeneity between what's happening on that original tumor biopsy and what's happening in the rest of the body. And so this begs the question, does HER2 expression on CTCs that predict a response to HER2 therapy? And this was a study that I thought to look into that by Fem et al. In the DETECT-3 study, which was a randomized controlled trial to look at adding patent those patients that are expressing HER2 on their CTs who were originally HER2 negative on the biopsy. So in order to understand this, they screened over 2,000 patients, find about 150 patients that were CTC positive for HER2. So less than the average 15% in those other studies. But when They identified the patients, they randomized them to standard therapy or standard therapy plus locatinib. And lo and behold, the patients that received locatinib plus standard therapy enjoyed a doubling of OS from 9.1 months to over 20 months. And so this kind of answers that question, can you act on HER2 status on CTCs? And the data is right here. The PFS did not reach statistical significance, but it was trending in that direction.
Isn't the patent kind of a dirty drug like against EGFR as well? It's not the
Yeah, so
cure for HER2.
right now, so this was an older study, but just kind of like steep trial. I had a great idea, but that was for CDK4/6 first line therapy.
That's what happens.
So,
It takes years.
but right, you guys are asking questions at the perfect time throughout this presentation. So, there's been such a huge surge of interest in HER2 expression now with DESTINY-Breast04, and there's so much progress being made because these patients showed HER2 low expression on the tumor biopsy. I'm talking about CTCs. But in patients that have a HER2 low expression on those tumor biopsy derive a benefit interest to trastuzumab deruxtecan. And so that led to the idea that we can therapeutically target HER2 even though its expression is low level. And in recognition of that, ASCO CAMP and NCCN guidelines are now reflecting the utility of HER2 low subgroup in their recommendations. And so previously, patients had to be in this 3+ category. Now this extends the population that are eligible for HER2 therapy, targeted therapy by 60%. I guess we could also add that since before low 6 has read out, to extend that to ultra low. And then in the last several weeks, DESTINY-Breast09, there's been some talk about the PFS benefit in first line therapy. That hasn't been reported yet. That's coming, maybe later this year. And so, on that note, at Menarini, we can see these things developing. And since we process a ton of CTCs and metastatic breast, prostate, and colorectal, we want to understand, that HER2 expression on those CTCs. And now we offer HER2 staining as positive, which would be 3+, or HER2 low would be 2+ or 1+.
I want to ask, based, what you saw on the left, 20 years later, 5 CTCs per 7.5 ml of blood remains a super low number of CTCs, right? So have you reconsidered your cutoffs? And then I'm also wondering, what is your range of CTC enumeration?
Dynamic range.
I'm sorry?
What's the dynamic range?
Yeah.
So this, it's a good question for So this patient, let me work into this, but the dynamic ranges, could be thousands. And in CMMCs, we have less blood because it's more disseminated. But for the myeloma test, I've seen numbers up to 40,000.
No, I'm talking about solid tumor.
Solid tumors.
Yeah.
So I don't know what the upper limit of detection is. Sometimes patients are so sick that the blood is very viscous and you have problems processing the sample. You have to dilute it.
In the PACE study, we had one with the 30,000.
30,000.
Yeah.
But 5 as a cutoff, does it still make sense?
Well, according to 20 years of data, when you look at different risk profiles or move that threshold up or down, 5 has always been the way that really kind of delineates the PFS versus OS, or PFS and OS. That's a good question, though.
But it's dynamic. Like every cutoff you try, you will see it. You're just defining more and more the one that have a more aggressive. So you always, even if you use 100 cutoff, you will still stratify patients based on prognosis. But the 5 is the most useful one because I think also of the distribution of the
Breast and prostate.
And I think what's critical actually on this point is that one reading, one snapshot in time, it's really hard to define, a patient's long-term response, right? So surveillance, and like the PREDICT study showed us, over time, is that number staying steady? Is it increasing? Is it decreasing? So it's really important to have that temporal association of CTC dynamics. So getting back to the clinical applications of the CTC HER2 assay, this was actually a patient. Before she was a patient, she was a 69-year-old female postmenopausal who had lethargic. She was low energy, just not feeling great. She went and saw her physician, and she was referred to hematology, who did a bone marrow biopsy. Bone marrow biopsy came back a lot of cancer cells. Referred the patient to breast cancer clinic, where they did this CT, and confirmed extensive bone marrow involvement. The breast MRI showed invasive lobular carcinoma with diffuse patterns. The tumor profile was luminal B-like, PR positive, PR negative, and HER2 negative. And so when, as you can see, upon ordering CTCs, those came back very high at 330 and incredibly 116 HER2 positive. So this was back in October of last year. At next follow-up, the patient was increasingly fatigued. Her CBCs showed that she had a low hemoglobin count, platelets were compromised, and the treatment plan was agreed upon to start with pertuzumab, trastuzumab, and letrozole. About a week later, letrozole was given. A week after that, anti-HER2 therapy. Remarkably, at follow-up in February of this year, see the PET-CT showed that the bone marrow involvement was completely devoid of those cancer cells. Breast MRI showed the same thing, that diffuse pattern of lobular was dissipated. And then, most impressively, the CTC result done at that time, we showed that all the CTCs were cleared. And of course, there was no HER2 positivity. So just looking at this graphically, it's quite impressive, and the patient's response just from last October until the beginning of this year, with HER2 targeted therapy based on the results of the CTC test, 130 HER2 positive cells gone, all the CTC cells gone. The patient, I understand, is doing very well, still on therapy, and so we'll have to keep an eye, on how this case develops to look at the durability of that response. I don't know if you want to add anything.
Yes, actually, we are using this test not only for addressing the treatment for the predictive value of GH2 expression, but we decided also to discourage the treatment because the patients have a lot of diarrhea side effect of the pertuzumab, and so we decided based on the results of the CTC and the PET scan that was doing well, and now her hemoglobin is 12 from 5.7, and we decided to discourage the treatment, and she's going on only with letrozole plus all the herceptin, all interest. And she's doing still very well.
So I want to transition into our Menarini search assay, which is our comprehensive genomic profiling using circulating cell-free DNA and RNA. So like many other circulating nucleic acid platforms, this test offers a lot of information on single nucleotide variants, copy number variation, insertions, deletions, it's all part of it. But since we incorporate RNA into the assay, we can provide more information in terms of RNA mutations. So not just looking at the genotype, the phenotype. Is that mutation or chromosomal abnormality being expressed? And as well, in addition to that, we also have readouts on fusions, translocations, rearrangements, clonality in the tumor and microenvironment. We do a comprehensive B and T cell repertoire analysis using RNA, so we can understand the clonal dynamics, patient's immune response. So using RNA also allows us to have this very high level of sensitivity. Limit of detection is 0.1%. And if we use a tumor-informed approach, we have a sample pretreatment, we can go down to 0.01%. And we receive many different sample types. We receive all of these, peripheral blood, bone marrow, hematology, tissues, FFP semples, and cerebral spinal fluid is very informative for this test as well. As you can see, there's many different applications in solid and liquid tumors, and I'll emphasize that we use a targeted approach. So we have a hotspot 300 genes that we interrogate, and we have over 1,600 RNA targets. And so this allows us to go to a read depth or sequencing depth of 25,030 years coverage of those targets. And so this is in comparison to some other tests that would be doing whole transcriptome, whole genome, home exome sequencing. We're not using all the reagents to cover all of those targets. Since we have this very focused approach, we can go down to this read depth, 1,030 years. Both the turnaround time for the CAT here, the CTC tests, 2 to 3 days. So that's a very quick assay to read out. And even Menarini search, the comprehensive genomic profiling, 7 to 10 days, I think, is an industry best in terms of NGS panel turnaround time. So how are these tests used complementary? Here's an example of a female, 49 years old, localized breast cancer back in 2019, hormone receptor positive, HER2 negative, IHC score of 0. She received first-line therapy, 2023, still liver metastasis, still hormone receptor positive, HER2 negative, IHC score of 0. CTCs were ordered. CTC came back with 20 and 1 positive HER2, which gave the physician confidence that they could start anti-HER2 therapy. This is a case that we're following, but importantly, using Menarini search, we also found other actionable mutations. In this case, it was PI3 kinase. So we, like I said in the beginning, feel that using both of these tests together is going to give us not only prognostic significance from CTCs and the HER2 and other biomarkers on CTCs, but actionable mutations from cell-free DNA analysis. And I won't read the summaries to you, but just kind of what I just mentioned, using both tests together, we feel like we are in a unique opportunity to really provide a better understanding, not just the patient's risk of progression, but the underlying biology that's driving them. These tests are run in our CLIA-CAP certified laboratory. The HER2 test, importantly, is New York State CLEP approved, as well as the CMMC and other tests that we have. So even though only the metastatic breast, prostate, colorectal original cell search have that FDA clearance associated with them, we run the rest of the tests under CLIA lab certification, and sometimes have been put through the rigor of New York State analysis. Yes.
Question. So you said for the cell-free RNA, you have a targeted panel. Do you have that list available?
Absolutely.
And you said you can look at T cells as well.
T and T cell.
Yeah, because I mean, what is the cost for academic if it's not like
a research test?
Yeah, research. Yeah, because we want to look at CAR T cells at the same time as tumor cells for lymphoma.
Okay.
As a proxy for activity in a combination of therapy. So we were interested to use cell-free RNA. Of course, the cell-free DNA will be useful also to look at the tumor cells from the lymphoma. But since it's still like it's going to be a clinical trial, just exploratory, I wonder if it's not prohibited because per patient.
Yeah, well, we do have an active research program, so I can follow up with you on one.
Yeah, and the list of genes will be
Absolutely,
very helpful.
Interestingly, yeah, okay, I'll follow up with you after this.
I have one question. Can your blood test for cell-free DNA be used to determine what type of cancer you have, or is it only after you know what type of cancer and then check for mutations?
So for CTCs, it's not meant for diagnosis. It's
No, the cell-free
yeah.
DNA.
So for the cell-free, it can be.
I have a question. I don't know if you will show next slides or.
No, this is it.
So like in myeloma, for example, like how was the sensitivity in those patients? How it was predicted as well? Because again, like the number of even plasma cells in the bone marrow would be very small. So how did you test the relevance or the impact of these circulating tumor cells in this patient systems?
So we have a paper, and I can forward this information as well, where we enroll MGUS smoldering and newly diagnosed multiple. MGUS on average obviously had much lower levels, but were detectable probably 67% of the time. And so how that translates into the risk of
In
progression.
clinical, yeah.
So we work with Irene Gabriel in
I know,
Harvard.
yeah.
And so, she's very active in understanding the risk, but that's more high risk smoldering. But we see customers ordering CMMC tests and smoldering patients or patients coming in because they have this gammopathy, and then they order our test, and sometimes it comes back with 10,000 CMMCs, and and the ordering physician is quite stunned. Like, how's that? Patient looks fine, but then they order about 2 months later, and it goes up to 25,000, and so it's giving you an indication that there's a process happening. Probably going to progress a lot sooner than somebody like a standard MS patient. And so we don't have thresholds established to say it's over this number, like so well established CTC. This is a newer assay, so we're still trying.
Are you doing anything further in prostate cancer, like looking at AR mutations or anything like that?
We are currently developing a PSMA, fourth channel marker. And there's a lot of talk about ARV7 for a while, but that's not the direction we're headed.
But people aren't using that so much
No.
anymore. There's other AR mutations, so go with the PROTAC drugs. So it's really pretty interesting.
Yeah,
But
I think
is it-
adding the cell-free component to CTC is going to be very informative for us.
You should probably be able to get those mutations from the cell-free DNA sequence. Yeah. So I would like you to comment on the use of EpCAM
Mhm.
and the fact that EpCAM gets downregulated during metastasis or lost in EMT. I would like to hear your
Yeah.
thoughts about that.
Sure, it's something that's an ongoing discussion at Menarini, right? And so that we get that question time and time again. And so, do we want to change our FDA cleared platform or offer that as a research tool? That's something that we discussed quite a bit, but we don't have that available right now.
Okay.
It's a very good question.
And we can go back.
Okay.
Thank you.
Thank you.
Frank. Also, if there are questions from Zoom, feel free to ask. Otherwise, with the CTC platform, with the liquid biopsy platform here at Cornell, we collaborate with Menarini a lot. Dr. Crispinelli used the test in the clinic, and so we have access to all the real world data, and there is a lot more actually that you can get in addition to what is reported in the report. So we have collaborations with them to have access to the actual file to evaluate for CTC clusters or for extracellular vesicles, the big one, not the exomes, but the large one that you can see, or quantify the expression of the markers. And so now, Letizia Pontolillo, which is a visiting fellow that has been with us now for quite a while, will talk to you briefly about the work that we are doing in clinical trial, but also in the real world setting to leverage even more the data that the cell search test offer.
Good afternoon to everyone. As Carolina said, we want to give you a little bit an overview of our data in the real world and in some clinical trial. What we can learn from CTC more than only the prognostic impact. We know that we can use CTC for the evaluation of predictive and prognostic biomarkers for drug screening, and also for have more insight into the biology of the metastatic formation. So this is again a presentation of the phase trial because I think it's one of the most important example of the predictive value of the CTC. And for the translation analysis, the CellSearch platform was used for the CTC enumeration and ER evaluation on the CTC at baseline, staging, and progression of disease. We saw in the previous presentation that the stratification of the population in stage 4 indolent or aggressive was predictive of more benefit for patients with aggressive disease for an escalation treatment. But Dr. Reduzzi and Dr. Serafini presented this analysis conducted on the samples classified as stage 4 aggressive disease, in which we evaluated the ER expression quantification on CTC with the asset software, and we consider ER positivity as the mean ER intensity more than 0. Overall, in all 3 time points, 32% of the CTC were considered ER negative. So we did a descriptive analysis in which we observed that the mean ER intensity in CTC was higher in the pool of samples at baseline compared with the pool of baseline of samples that we analyzed at the moment of progression of disease. And in the same way, also the percentage of ER positive CTC was higher in the samples collected at baseline, 20.3%, while at the progression of disease, the rate of the ER positive CTC was only 5.5%. Then we described the distribution of stage 4 indolent, stage 4 aggressive ER positive, and stage 4 aggressive ER negative samples across the 3 different time points. As we can see at the baseline, only 5% of the samples collected were classified as stage 4 aggressive ER negative, while in the pool of samples analyzed at the time of progression disease, the rate of stage 4 aggressive ER negative samples was more or less 18%. What we can conclude, putting together all these observations, that probably the ER expression on CTC, the quantification of ER on CTC, could be helpful to understand the mechanism of resistance to the endocrine treatment, both with the targeted therapy with CDK4/6 inhibitor and eventually also with avelumab. But beyond the CTC, the predictive value of the CTC enumeration and the ER expression that was conducted in the phase trial, we know that another important biomarker that we can analyze on CTC is the H2. And so far, we know that the unique clinically validated test is the tissue biopsy that has several limitations because, as we know, it's an invasive procedure that can expose the patients to some risk, and not always we can have a metastatic site that is accessible with the tissue biopsy. And this is the reason for which we know that circulating tumor cell can give us some insight in the H2 expression in a real-time way, because we can repeat several times the liquid biopsy and the H2 assessment. But there are some cons that we need to keep in mind, because the H2 evaluation on CTC is not still clinical validated, and we still need standardized H2 evaluation methods to validate this kind of approach. And for this reason, we conducted a retrospective analysis in the cohort of patients enrolled at Northwestern University in the Biosystems trial, and we analyzed a cohort of 144 patients with hormone receptor positive HER2 negative metastatic breast cancer, classified as stage 4 aggressive disease for the CTC enumeration. First of all, we analyzed the feasibility of the quantification of the H2 expression on CTC using again the asset software. And then we used a CTC H2 ratio calculated as the presence of CTC 3 plus and 2 plus H2 expression divided for the total CTC amount in each sample. And then we did a comparison with the tissue H2 status, considering the closest tissue biopsy to the blood draw that we considered for the CTC. And what we observed that the H2 CTC ratio was a good tool for concordance so to predict the H2 value on tissue, but moreover, what this kind of analysis suggested is there is a clinical space for the validation of the H2 assessment on CTC that can can give us more information compared to the tissue biopsy, that is something that is static and not real-time assessment of this kind of biomarker. But not only so the HER2 expression on CTC as a tool for guided treatment, but also the HER2 expression on CTC could be again a predictive biomarker. This is a small retrospective analysis that we conduct among 50 patients that received CDK4/6 inhibitor plus endocrine treatment in first line. And we observed that the proportion of patients with at least one HER2 expressing CTC before starting the treatment was numerically higher among patients who had disease progression, 42%, compared with the cohort of patients that were still responding to treatment, 28%. As usual, there are some limitations of this analysis because it's a retrospective analysis with a small sample size, but that give us some suggestion that we need to test all these biomarkers to have a more complete understanding of the mechanism of resistance and for our patients. So putting all this data together, this suggests that liquid biopsy can help the clinician, both using different biomarker, liquid biomarker, ctDNA for identifying the mutation that we can address with the treatment, but also CTC, not only in terms of enumeration, but also with the biomarker expression like ER and HER2 positive, can help us to address the best treatment for our patients. Beyond the clinical utility in terms of prognostic and predictive biomarker, the CTC can also give us some information regarding the biological aspect of our tumor. In fact, this is a collaboration of the Cristofanilli lab with the Monsana team, and they observed that the bone microenvironment promotes the release of HER2-positive CTC, which contributes to secondary metastasis formation, always in the setting of hormone receptor positive HER2-negative metastatic breast cancer. So recently, we published this position paper in which we reinforce our idea that CTC, both with the enumeration and the biomarker expression, can help us to tailor the best treatment for our patients. And this is a proposal of a phase 2 umbrella trial in which we think that should be helpful to test in a prospective way on a cohort of patients in which the treatment could be addressed based on the stratification of the patients on the enumeration of CTC, stage 4 indolent, stage 4 aggressive, in order to demonstrate that patients with a stage aggressive disease based on CTC enumeration could benefit of an escalation treatment. For example, now that we have ADC, probably these patients can benefit more from this kind of aggressive treatment. So in conclusion, we can say that phenotypic characterization of CTC can provide information and should be performed in addition to the mere enumeration, that HER2 can be evaluated on CTC, correlates with HER2 positivity on tissue, and has also a prognostic and predictive value. ER can be detected on CTC, and we need more prospective study with a large sample size to validate its value. And not only the ctDNA, but also the CTC analysis can reach a deeper understanding of the diverse process underlying the tumor progression of our patients. Thank you.
Are there any questions for Letizia?
How often do you see new mutations when you're looking at CTCs?
So now, so far in clinical practice, what the information that we have by the test are the enumeration and the HER2 expression.
So you have not looked at.
We don't have data about mutation.
The mutations is done on the ctDNA.
On the ctDNA.
So these patients undergo both tests in the clinic.
We are going to start to have some information also regarding the R expression in CTC. This is the next step, one of the next projects, and so we will try to combine in a real world all these data to understand how to manage our patients.
And since you have cell-free RNA, have you looked at CHIP? Clonal hematopoiesis?
No, because for the test that we use, they just give us the result with the eventual mutation, but we are not looking at this kind of information for addressing.
But you're using this in the clinic now regularly, or just in the research program?
No, we are using regularly. Dr. Cristofanilli uses regularly. In general, we monitor patients both with CTC and ctDNA.
But then all of these studies that were presented are done, using this data
more as for exploratory
Yeah.
Analysis with the research protocol that we have that allow us the data basically.
And as you saw, we are using the asset software to have more information regarding.
I mean, I saw a lot of Italian authors on some of the papers, I think these were research studies, the other ones that you were showing.
The base study was obtained by trial, and the study that
So your name, Italiano, the people I know, the
Just
Italian
all
research.
Italian.
And the
No, but I mean,
Yeah,
even
they
though the
have
other
the
papers,
collaboration. They have a
collaboration with Milano.
Yeah, they do
Yeah.
a lot of trials.
well, the PACE was actually a US trial. The PI is Dr. Meyer from Dana Farber. But yeah, Dr. Christoph Panilli and a lot of collaborators.
I just want to add that in our cell-free DNA RNA testing, we offer chip.
Yes, so I was just curious in the context, I mean, I'm thinking also about blood, like actual blood. And the patients that might be at risk of transforming because of therapy to secondary malignancies, like in the hematopoietic lineage, you might have a way to one detect people that might have pre-leukemic mutations or the mutation chip. And that might also guide what might put them at risk. I mean, I'm always thinking about blood. But it was just interest. Yeah.
Letizia, is it well characterized? You're talking about the egress from the bone marrow, that process, or?
I think that Karina can speak more about the bone process. So what they showed is that the F2 positive CTCs was correlated with the higher incidence of.
That study was mainly done in mice, and they showed all the mechanism in mice. But what we did with the CTCs from the patients was to see if there was an association between in HR positive HER2 negative metastatic patients between HER2 expression on CTCs and the presence of bone metastasis. And we saw that patients with bone metastasis actually had more HER2 expression on the CTCs. So now the next step would be to try to do this prospectively, following patients that do not have the bone metastasis, patients that have only bone metastasis, and see if we can prove their theory in patients longitudinally, if actually the bone induce an increase of HER2, and so spread to secondary organs, because that's what they saw in the.
There's something about the bone marrow microenvironment that encourages HER2 expression.
Yeah. And also there was another marker that was more relevant. Like HER2 was the one that we could test on CTCs, but was actually energy-free, the one that was more related to this signaling pathway. Yeah.
People online.
Yeah. Everybody, we're actually over time, but if anybody online has a question, please. No,
Would be interesting.
I don't think so. So, oh yeah, maybe.
Said they're working on chip. That's right.
All good, all good.
Okay. All right. So I think we can conclude. Thank you, everybody, to come to the.
And thank you for
seminar.
lunch.
Thank you, Franny.
You should have made it very clear there was food.
Hey, I was going to for congratulations on